Next topic is renal transplantation. This remains the best treatment option in case of end stage renal disease, provided the patient has a good, adequately matched renal donor. The results are best with the living related transplantation. This is because in living related donor there is an optimized tissue matching and ischemia time is reduced. The next best option is unrelated donor kidney transplantation. Here the rejection rates are quite higher compared to the living donor who is related, but it is less than kidney from a deceased donor. As a general rule, pre-transplantation blood transfusion should be avoided, as this leads to development of sensitization to unmatched HLA antigens and increases the risk of rejection. And if blood transfusion is absolutely necessary, leukocyte reduced irradiated blood can be used. There are various factors which influence the graft survival, and these include HLA mismatch, pre-sensitization, that is preformed antibodies, very young or older donor age, female donor sex, African American donors, at risk APOL1 donor genotype, older recipient age, diabetic kidney disease in the recipient as the cause for end stage renal disease, prolonged cold ischemia time, a coexisting hepatitis C infection, a larger recipient body size. All these factors reduce the graft survival except the older recipient age, which increases the graft survival. Now let's look at the contraindications in case of renal transplantation. There are absolute contraindications and there are relative contraindications. Absolute contraindications include active glomerulonephritis, an active infection, recent malignancy, overt AIDS, active hepatitis, and even severe comorbidities. Relative contraindications include severe psychiatric disease, hepatitis C with chronic liver disease including cirrhosis, non-compliance with medications or dialysis, multiple myeloma, oxalosis, and even amyloidosis. In general, the patient should have a more than 5-year survival to undergo renal transplantation. Now let's look at graft rejection post dialysis. The graft rejections can be hyperacute due to pre-sensitization with incompatible HLA antigens, or it can be acute where there is a change or decline in renal functions over several weeks to months, generally less than 6 months. The clinical features of rejection include increase in serum creatinine levels. Patient can develop hypertension, fever, reduced urine output, and there can be graft tenderness also occasionally. Diagnosis is made by percutaneous renal biopsy of the transplanted kidney. Treatment usually involves a pulse methyl prednisolone therapy, or if the rejection is antibody mediated, then patient can be subjected to plasmapheresis or anti-B cell therapy. Now let's look at the immunosuppression post-renal transplantation. The treatment usually involves a 3-drug therapy, with each drug targeting different stages of immunologic response. The first one is calcineurin inhibitors. The second one is prednisolone. And third one is mycophenolate mofetil. Examples of calcineurin inhibitors include tacrolimus, cyclosporin. Cyclosporin is the most potent oral calcineurin inhibitors, and it has drastically improved the short-term survival. The adverse effects of calcineurin inhibitors include hyperkalemia, hypertension, hirsutism, a resting tremor, gingival hypertrophy, hyperuricemia, hyperlipidemia. Tacrolimus, which is a fungal macrolide, has very similar action to cyclosporin, and it does not cause gingival hypertrophy or hirsutism. Calcineurin inhibitor is associated with de novo diabetes, especially when used long term, and FDA has recently approved a new co-stimulatory blocking antibody called belatacept to prevent long-term calcineurin inhibitors complications. Prednisolone is used in conjunction with cyclosporin for the first few months post-transplantation. Adverse effects include hypertension, worsened glucose tolerance or glucose intolerance, obesity, osteoporosis, gastroesophageal reflux disease, acne, depression, dyslipidemia, Cushingoid features, and mood disturbances. Mycophenolate mofetil is better when compared to azathioprine, and this is also used in conjunction with calcineurin inhibitors. Adverse effects of mycophenolate mofetil include diarrhea, which is the most common one, and patients can develop leukopenia and even thrombocytopenia. When calcineurin inhibitors are not given, sirolimus is an alternative immunosuppressive medication. Other complications of renal transplantation include infections and neoplasias. Infections are common, especially in patients receiving cadaveric organ transplantation, as there is a higher incidence of rejection requiring increased frequency of pulse steroid therapy. The organisms implicated in the development of infection depend upon the duration from renal transplantation. During the peri-transplantation period, that is approximately 1 month, wound infections are very common. Even herpes virus or oral candidiasis is common. Patients can also have urinary tract infections. In the next 1 to 6 months, the usual organisms implicated in infections include cytomegalovirus, pneumocystis carnii, listeria, legionella, hepatitis B and C, and beyond 6 months, patients are at a higher risk from infections from nocardia, BK virus, also called as polyoma virus, hepatitis B and C, herpes zoster, aspergillus. Some important points to note about the infections include prophylactic ganciclovir or valciclovir reduces the infections from cytomegalovirus. Daily low dose of trimethoprim sulfamethoxazole helps in preventing pneumocystis carnii pneumonia infections. Polyoma DNA viruses, or also known as BK virus, is reactivated during immunosuppression, and they produce a characteristic renal rejection pattern involving inflammation and BK nephropathy, and the treatment is usually to reduce the immunosuppression to clear the BK virus. Epstein-Barr virus is associated with lymphoproliferative diseases and even non-Hodgkin's lymphoma and squamous cell carcinoma of skin is common in these patients. Next, let's look at abnormalities of urine. There are two important subheadings. The first one is abnormalities of urine volume and abnormalities of urine composition. The first topic is oliguria and anuria. This is a reduction in urine volume, and for oliguria it is less than 400 ml per day, and for anuria it is less than 100 ml per day of urine. But a generally accepted clinical definition is oliguria is considered when the urine output is less than 0.5 ml per kg per hour, and anuria is when there is less than 0.3 ml per kg per hour of urine output. Oliguria usually happens in a patient with volume depletion, and this can also result in pre-renal azotemia. Anuria can be caused by complete bilateral urinary tract obstruction. It can also be caused by vascular catastrophe, such as dissection or even arterial occlusions. Other causes of anuria include renal vein thrombosis, renal cortical necrosis, severe acute tubular necrosis, shock, even cardiogenic or septic shocks, along with hypovolemic shocks. Certain drugs such as NSAIDs, angiotensin converting enzyme inhibitors, or even angiotensin receptor blockers. Next condition is polyuria. Urine volume of more than 3 liters per 24 hours is considered as polyuria. Patients of polyuria also have nocturia and increased frequency of urination. There are three underlying pathologic mechanisms for polyuria. The first one is increase in fluid intake. The second one is increase in solute load, such as hyperglycemia. Third is inadequate antidiuretic hormone action. Now, this inadequate antidiuretic hormone action is further divided into two: reduced ADH levels from the brain or central nervous system, and reduced sensitivity to ADH at the level of kidneys. Now, the reduced ADH from CNS is called central diabetes insipidus, and reduced sensitivity to ADH in the kidneys is called nephrogenic diabetes insipidus. Now, let's look at the causes of polyuria. Excessive fluids. This can be intravenous fluid administration, or it can be oral intake of excessive water. This is called primary polydipsia. Certain therapeutic agents, including diuretics, can cause polyuria. Osmotic diuresis, which is caused by hyperglycemia, azotemia, mannitol, and radio contrast. Here the solute load is high, because of which there is increased water being excreted out, that is increased urinary volume, causing polyuria. Nephrogenic diabetes insipidus can be caused by lithium and certain other drugs, or urinary tract obstruction, papillary necrosis, reflux nephropathy, interstitial nephritis, hypercalcemia, or there can be hereditary causes. Central diabetes insipidus is caused by tumors of the CNS, post-operative period, head trauma, bacillar meningitis, neurosarcoidosis. Let's now look at the approach to polyuria. That is, in a patient with urine output of more than 3 liters per day, the first thing that is checked is urine osmolality, which is either less than 250 milliosmoles or more than 300 milliosmoles. With a urine osmolality of more than 300, patient can have solute diuresis, and patient needs to be investigated for hyperglycemia, mannitol, hyperuricemia, increased urea levels, possibly from high protein feeding, medullary cystic diseases of kidney, resolving acute tubular necrosis or diuretic use, or even obstruction of the urinary tract. In patients with urinary osmolality of less than 250, review the history, and if the patient has serum sodium levels which are low, the diagnosis is likely to be primary polydipsia, which can be either psychogenic or with an underlying hypothalamic disease, or certain drugs such as thiorizodine, chlorpromazine, and certain anticholinergic agents may cause polydipsia. These patients should also be subjected to a water deprivation test, followed by antidiuretic hormone analog administration. This can have two possible outcomes. Either the urine concentration remains dilute after both water deprivation as well as ADH analog administration, or the urine concentration increases after the ADH analog administration. In the first case, we are dealing with a nephrogenic diabetes insipidus, which is resistant to or not responding to the ADH that is administered, and the second one, that is where the patient's urine concentration increases after the ADH administration, we are dealing with a central diabetes insipidus. Drugs implicated in nephrogenic diabetes insipidus include lithium, demeclocycline, ethanol, methoxyflurane, diphenylhydantoin, propoxyphene, and amphotericin. Now the abnormalities of urine composition. The first one is proteinuria. This is the hallmark of glomerular disease. In normal population, a proteinuria of up to 150 milligrams per day is accepted as normal. Urine proteins contain albumin, which is a heavy or large molecule, and it can also contain light chains of immunoglobulin, which are smaller molecules. Urine dipstick methods usually detect only the albumin and hence gives the albuminuria picture, whereas the light chains are not detected by most of the commercially available urine dipsticks, requiring further special assays with sulfosalicylic acid. Urine albumin levels of 30 to 300 milligrams per day is considered as moderate albuminuria. This was previously called microalbuminuria, and urinary albumin levels of more than 300 milligrams per day is considered as severely increased albuminuria, which was previously called macroalbuminuria. A gradual increase in albuminuria is classically seen in diabetic nephropathy and indicates a decline in the renal function. The exact measurement of proteins in the urine requires a collection of 24-hour sample of urine, and the assays are done on that. But as spot urine protein to urine creatinine ratio can give a rough estimate of the proteinuria. A urine protein creatinine ratio of 3.0 indicates that the proteinuria is approximately 3 grams per day. Proteinuria of 500 milligrams to 3 grams per day can be due to non-specific causes. A transient proteinuria of 500 milligrams to 1.5 grams per day is seen with fever, vigorous exercise, change in body position, or even in heart failure. A proteinuria in the range of more than 3 grams per day is considered as nephrotic range, and if there is associated hypoalbuminemia, dyslipidemia, leading to increased cholesterol levels and edema. This together is called nephrotic syndrome. Severe degree of proteinuria can be seen with minimal change disease, focal, segmental, glomerulosclerosis, membranous nephropathy, diabetic nephropathy, collapsing glomerulopathy, HIV associated nephropathy. All of these can have very high range of proteinuria, with numbers even reaching more than 10 grams of protein per day excreted in the urine in cases of minimal change disease. Medications used to reduce the proteinuria levels include ACE inhibitors or angiotensin receptor blockers and SGLT2 inhibitors. The next abnormality of urinary composition is hematuria. Gross hematuria is seen usually in patients with lower urinary tract disease, and it is not seen with interstitial diseases of the kidney, except cyst rupture in polycystic kidney disease or post-pharyngetic flares of IgA nephropathy, where there is hematuria associated with an intrinsic renal disease. In patients with microscopic hematuria, that is RBCs of more than 1 to 2 cells per high power field, associated with proteinuria, hypertension, and presence of urinary sediments, is suggestive of nephritic syndrome. And examples of such conditions include post-streptococcal glomerulonephritis. Let's look at causes of hematuria. These can be divided into causes pertaining to lower urinary tract and causes pertaining to upper urinary tract. In lower urinary tract, the causes include bacterial cystitis, interstitial cystitis, urethritis, kidney stones, bladder carcinomas, schistosomiasis. Upper urinary tract, renal cell carcinoma, age-related renal cysts, other neoplasms including oncocytomas or even hamartomas, congenital renal cystic disease including ADPKD, acquired renal cystic disease, glomerular diseases, pyelonephritis, renal infarction, hypercalcemia and hyperuricosuria, and even nephrolithiasis. In hemolysis or rhabdomyolysis, although urine microscopy does not show any RBCs, the patient will have urinary dipstick positive for blood. Acanthocytes or dysmorphic RBCs are usually seen in cases with glomerular diseases. These patients may also have RBC casts, but they have lesser sensitivity compared to acanthocytes. Let's look at the evaluation of hematuria. The first test to be done is to see if there is proteinuria of more than 500 milligrams per day, and associated dysmorphic RBCs. If these are present, then the patient must further be subjected to serologic and hematologic evaluation, and vasculitis and SLE workup needs to be done, including anti-GBM antibodies, ANCA profiles, complement levels, cryoglobulin levels, tests to detect hepatitis B or hepatitis C, HIV, VDRL, and even anti-streptolysin O titers need to be conducted. And after this, the patient can be subjected to renal biopsy to come to a pathologic diagnosis. If proteinuria and dysmorphic RBCs are absent, the next test to be done is to see if the patient has pyuria with WBC casts. Now, if these are present, then the patient's urine must be subjected to culture sensitivity and patient should be treated accordingly. If they are absent, then further evaluation with hemoglobin electrophoresis, urine cytology, urine analysis of family members, 24-hour urinary calcium or uric acid should be assessed. If all these are normal, then the patient must be subjected to intravenous pyelography and renal ultrasound. If there are abnormalities present, here patient can be subjected to retrograde pyelography or even arteriogram or cyst aspiration. And if IV pyelography is normal, cystoscopy, where if found significant, patient's biopsy can be taken from the lesions in the cystoscopy and this will be further followed up. If cystoscopy is normal, patient can be subjected to renal CT scanning, and if there is a mass or a lesion, a further biopsy of the mass or the lesion can be subjected to pathological tests. And if this is normal, patient can be followed up with periodic urine analysis. Let's now look at glomerular diseases. The first one among them is acute glomerulonephritis. Historically, it is also called as nephritic syndrome. Clinical features of acute glomerulonephritis include hematuria, hypertension, edema, and proteinuria, and rarely patients can have oliguria as well. These symptoms usually develop over days. The underlying pathologic mechanisms include reduced GFR or glomerular filtration rate leading to water and salt, proteinuria of less than 3 grams per day called as nephritic range of proteinuria, and hematuria leading to RBCs and more importantly RBC casts within the urine during urine analysis. Acute glomerulonephritis is mediated by humoral immune mechanisms. Let's now look at the causes of acute glomerulonephritis. The first one is infections, and broadly there are two types. The first one being post-streptococcal glomerulonephritis, or written as PSGN in short, and the second one is non-streptococcal post-infectious glomerulonephritis. The implicated organisms include bacteria, viruses, and parasites. There is another type called IgA dominant post-infectious glomerulonephritis, which is caused by staph infections. Bacterial infections include infective endocarditis, shunt nephritis, meningococcemia, syphilis, typhoid, pneumococcal pneumonia, and even sepsis. Viruses that are implicated in development of acute glomerulonephritis include hepatitis B, Coxsackie virus, varicella, vaccinia, measles, mumps, infectious mononucleosis, and even echovirus. Parasitic infections that are implicated include malaria and even toxoplasmosis. The second important cause is multi-system diseases. These include SLE, systemic lupus erythematosus, vasculitis, Henoch-Schönlein purpura, and even Good-Pasture syndrome. Primary glomerular diseases include mesangiocapillary glomerulonephritis, IgA nephropathy, or also called as Buerger's disease, even mesangial-proliferative glomerulonephritis. Miscellaneous causes include Guillain-Barré syndrome, radiation therapy for Wilms tumor, self-administration of diphtheria, pertussis and tetanus vaccine, and even serum sickness. Let's look at some of the important causes of acute glomerulonephritis in depth. The first one is post-streptococcal glomerulonephritis. This forms the prototype for acute glomerulonephritis. Disease usually presents after 1 to 3 weeks following a streptococcal throat infection, where the implicated organism is a nephritogenic streptococcal bacteria, which belongs to the A beta hemolytic streptococcal species. It is the most common cause in childhood. Patients can have a positive history of sore throat in the prior weeks. They can also have evidence of infection in throat swabs for cultures or even skin culture. Elevated titers for anti-streptococcal antigens. These include anti-streptolysin O antibodies, anti-DNase antibody, and even anti-hyaluronidase antibodies. Treatment usually involves correction of fluids and electrolytes. In most cases, it is self-limiting. However, if there are any complications, it is more in adults. In post-infectious non-streptococcal glomerulonephritis, control of disease by antibiotics usually resolves the nephritis. Patients may require glucocorticoid therapy as well. This is usually done to prevent progression to dialysis. The next type of glomerulonephritis is rapidly progressive glomerulonephritis, also called as RPGN. It is defined as subacute reductions in glomerular filtration rate more than 50% with evidence of proliferative glomerulonephritis on biopsy. The causes have an overlap with acute glomerulonephritis. Rapidly progressive glomerulonephritis is divided into 3 subtypes based on the biopsy findings. The first subtype is immune complex associated. The example is SLE. The second one is pauci-immune, usually associated with anti-neutrophilic cytoplasmic antibodies. And third is associated with anti-glomerular basement membrane antibodies. This includes Good-Pasture syndrome. On light microscopy, all the 3 subtypes have crescentric glomerulonephritis with proliferative pattern, but their characteristics vary in immunofluorescence. and electron microscopy. Let's look at the causes of rapidly progressive glomerulonephritis. These are classified as infections, multi-system diseases, drugs, and even idiopathic or primary glomerular diseases. Infections include post-streptococcal glomerulonephritis, which is the most common cause, infective endocarditis, occult visceral sepsis, hepatitis B with cryoglobulinemia, HIV, and even hepatitis C virus with cryoglobulinemia. Multisystem diseases include systemic lupus erythematosus, good Pasteur's syndrome, Henoch-Schönlein purpura, systemic necrotizing vasculitis, including granulomatosis with polyangiitis, essential mixed cryoglobulinemia, relapsing polychondritis, rheumatoid arthritis. Drugs include penicillin, allopurinol, cocaine, hydralazine, and rifampin. Idiopathic is further divided into idiopathic crescentric glomerulonephritis and diseases that are superimposed on other glomerular diseases. Causes of idiopathic crescentric glomerulonephritis include type 1 with linear deposits, which are mediated by anti-GBM antibodies, type 2 with granular deposits mediated by immune complex, type 3 that is quasi-immune with no deposits, anti-neutrophilic cytoplasmic antibody induced, immunotactoid glomerulonephritis, and even fibrillary glomerulonephritis. The ones that are superimposed on other primary glomerulonephritis include mesangiocapillary glomerulonephritis, membranous glomerulonephritis, and even IgA nephropathy or Buerger's disease. Let's look at some of the important forms of these rapidly progressive glomerulonephritis. The first one being SLE associated RPGN. Here the renal involvement is due to the deposition of circulating complexes. Clinical features of SLE with or without renal involvement include photosensitive rashes called butterfly rashes, arthralgias, alopecias, and CNS involvement. Renal biopsy shows diffuse glomerulonephritis, which is the most common. These patients have characteristic active sediments, severe proteinuria, and a progressive renal insufficiency. These patients may have a poorer prognosis. Other biopsy patterns can be focal or mesangial or membranous glomerulonephritis. Laboratory findings in patients with SLE include hypocomplementemia, that is reduced C3 and C4 levels in particular. They will be positive for anti-nuclear antibodies, especially anti-dsDNA antibody. Treatment includes steroids, cytotoxic agents, and even mycophenolate mofetil. The next important cause is anti-GBM neutrophilic, cytoplasmic antibodies, or ANCA associated glomerulonephritis. They are also a form of quasi-immune glomerulonephritis. These can be either renal limited or also called idiopathic quasi-immune glomerulonephritis, or they can be associated with systemic diseases such as granulomatosis with polyangiitis, previously known as Wegener's granulomatosis, or even be associated with microscopic polyarteritis nodosa. The characteristic finding of this disease is circulating anti-neutrophilic cytoplasmic antibodies. There are two important types. The first one is P-ANCA, the second one is C-ANCA. They are detected by immunofluorescence of alcohol fixed neutrophils. P-ANCA shows a perinuclear pattern and C-ANCA shows a cytoplasmic pattern. P-ANCA is associated with antibodies against myeloperoxidase, and hence P-ANCA is also known as MPO-ANCA. And cytoplasmic ANCA is associated with antibodies against proteinase 3, or also called as PR3 ANCA. It is important to confirm the presence of MPO or PR3 ANCA by ELISA. This is because P ANCA is not only caused by MPO ANCA, certain other anti-neutrophilic antibodies can also show a perinuclear pattern. One important example is antibodies against lactoferrin, which can have a P-ANCA pattern, but it is not associated with quasi-immune glomerulonephritis. One important thing to note is that the ANCA titers do not correlate with disease activity. Patients of RPGN can typically have flu-like prodromes. This includes fever, myalgia. There can also be anorexia and even weight loss in some patients. There can be symptoms of systemic diseases. These may include neurologic, such as mononeuritis multiplex. There can be upper respiratory tract involvement, as seen as sinusitis. There can be cutaneous and even lower respiratory tract symptoms. In patients with pulmonary necrotizing capillaritis, there can be associated hemoptysis and even pulmonary hemorrhage. The standard initial therapy for RPGN involves a combination of methylprednisolone plus cyclophosphamide. An alternative medication is rituximab, which targets CD20, which is an anti-CD20 monoclonal antibody, and this helps by B cell depletion. Other modalities include plasmapheresis, but this is not beneficial in acute kidney injury alone. It may be used when it is associated with pulmonary hemorrhage. Cyclophosphamide, on the other hand, is continued until stable remission, which usually takes up to 3 to 6 months. These patients on treatment should require prophylaxis for pneumocystis carniae pneumonia or pneumocystis jirovecii pneumonia. This is given as trimethoprim sulfamethoxazole once daily medication. Other alternatives for prophylaxis include dapsone or even atovaquone. Most of these patients will require a long-term immunosuppression which is given by oral medications. But in patients who are treated with rituximab, patients will require rituximab as a continuation therapy at regular intervals. But studies have shown that rituximab has a better outcome compared to the oral immunosuppression. Next, let's look at anti-glomerular basement membrane disease or anti-GBM disease. It is caused by antibodies against alpha-3 NCI, that is non-collagenous domain of type 4 collagen. The diagnosis is established by circulating anti-GBM antibodies and renal biopsies revealing linear deposition on immunofluorescence. Patient can have isolated glomerulonephritis, or there can be associated pulmonary hemorrhage. In this case, with association of pulmonary hemorrhage, it is called as good pasture syndrome. Up to 10 to 15% of the patients may show ANCA positivity, and this ANCA will be MPO ANCA, which is positive. Some patients may also have symptoms of vasculitis, and this includes cutaneous leukocytoclastic vasculitis. Patients are treated with plasma exchange, which produces remission. If there is associated pulmonary hemorrhage, then the patients may require IV glucocorticoids as pulse steroid therapy. Some markers, if present, are associated with poor prognosis, and these include more than 50% crescents on renal biopsy and serum creatinine of more than 5 to 6 milligrams per deciliter. The next topic is Henoch Schönlein's purpura, or HSP in short. This is a generalized vasculitis that occurs mainly in children. It is characterized by IgA nephropathy, purpura, arthralgia, and even abdominal pain. Patients usually present with proteinuria and hematuria. Renal biopsy is used to prognosticate. Treatment is generally supportive.